Might wonder why, when it was discussed in detail yesterday, why we need another session today. This is just to clear a few murky points which are not very clear. Still we have some doubts on it, just for that purpose. So there are so many queries, so many worries whenever you get a GDM patient. All of us are agreed on the universal screening, but when should we start screening? If negative, should we repeat? If yes, when all should we repeat? What are the cutoffs? What are the management recommendations? Whether only insulin, as it was told earlier, or we can use OHAs also. Which are the safe ones we can use in pregnancy? When do we terminate, or and what advice should we give the lady in the postpartum period? So we expect that Dr. Umaram, our esteemed faculty, will be providing us with the answers to all this. So Dr. Umaram, over to you.
Thank you very much, Lola. So we're going to focus in the next about 8 minutes or 9 minutes on aspects of gestational diabetes. So the first question that has been asked is about screening. So screening for gestational diabetes, whom should we screen, when should we screen, what should we screen with, and which criteria should we use? I think these are the areas where there is confusion. I think we'll start with areas where there is no confusion because we are an ethnically high-risk population. Even if you choose to do criteria-based screening, we will fall under the category who need universal screening, and therefore universal screening is the norm. We screen at first contact, which is whenever that is, even if it is in the early first trimester, and then again at 24 to 28 weeks if they are negative, or screen with normal glucose at booking. And what screening do we use? Practically we have two choices: the 75 gram 2-hour GTT, which is the gold standard, and then the non-fasting glucose challenge, or DIPSI, which is currently the national guideline. And what criteria should we use when we use the GTT? So the recommendations by many bodies include universal screening for our population, and this is from the FIGO guidance. And what the confusion comes because we are trying to balance evidence with practicality, and so I just want to focus on a little bit on which test. The 75 gram fasting OGTT is what is universally recommended by IADPSG, WHO, FIGO, NICE, and ADA. Of course, the cutoffs that most bodies have used in unison is what came out of the HAPO study, which is 92, 180, and 153. NICE uses 100 and 140 as the cutoff from the fact that the adverse outcomes are more with the higher fastings, and in the range between 92 and 100, really they don't see that much of morbidity. And in the other side of the Atlantic, they still believe in doing a two-step screening, which surprisingly many people are still following in India. I think given that the percentage of women who are going to screen positive and then have another GTT, it probably doesn't make sense, and the Carpenter and Couston criteria are no longer valid. They are based upon the risk of the woman then subsequently developing type 2 diabetes, has nothing to do with pregnancy outcomes. And Carpenter and Couston, I mean, they themselves talk about the fact that their cutoffs are no longer relevant, so we really should not be using those numbers at all. The non-fasting 75 gram 2-hour test, which is the DIPSI test, is a cutoff of 140 after 2 hours with a glucose load given at any point in time. Now, if you see the FIGO guidance, if you are in a fully resourced setting, then you would do a 75 gram fasting test. If you are in a low resource setting, then they say do what is convenient for you. India is a country which, we have centers which are as good as fully resourced, and many centers which are under-resourced, where women may not come in the fasted state, and therefore if you cannot offer any screening at all, it makes sense to do a non-fasting test. But if you are in a center where women are willing to come in the fasted state and you can do the screening with a GTT, then that is the gold standard. Why? Because even though the DIPSI test has been shown to be validated in one paper where it correlates perfectly with the 75-gram GTT. The sensitivity of the test has been shown to be low in many studies. So you don't want to use a test with low sensitivity when you are dealing with a population which is at extremely high risk, and many studies from India, Sri Lanka suggest that you may miss as high as 23% of gestational diabetes when we use the test. Now, having screened, what is the other important message I want to give is don't use different screening tests in different trimesters for the same woman. So you decide what you want to do and do that consistently. With regard to management, there's a lot of evidence about OHAs. Mainly metformin and glyburide are the medicines that are used. Both cross the placenta, and both concerns are the impact on adiposity and metabolism. There's a similar need for additional insulin whether we use metformin or glyburide, similar perinatal mortality and neonatal hypoglycemia. But with metformin, there's less macrosomia, there's lower mean birth weight and less gestational weight gain, and you can see that the strength of evidence is in favor of metformin. And there are a lot of publications and meta-analysis which compare the drugs, and in general, if you see comparing glibenclamide with insulin, glibenclamide performs poorly whether we are looking at birth weight or neonatal hypoglycemia, whereas when you look at risk and benefit of the use of metformin in pregnancy over insulin, there is a tendency for metformin to have less neonatal hypoglycemia, less NICU admissions, and less maternal weight gain. And this is probably true of women who have more insulin resistance when they enter pregnancy, and also a tendency to reduce the incidence of hypertensive disorders in pregnancy. So these are the benefits. Obviously, there are going to be a group of women who will need insulin additionally, and so when you compare glibenclamide versus insulin, as I said, there's far higher hypoglycemia and twofold higher macrosomia. So I don't think that's a drug which would be beneficial for use. So metformin becomes the OHA of choice in the management of gestational diabetes. And metformin failure, of course, is more common in women who have a much higher BMI, much higher fasting levels, and generally, if it fails, you need to add insulin and not another oral hypoglycemic agent. And I think those are important criteria to keep in mind. I'm not talking about timing of delivery in the interest of time, because it's difficult to cover everything in 8 minutes, and we discussed that yesterday in the session. Postpartum follow-up is extremely important. Most of the time, immediate postpartum need, we don't need to check glucose values, because many women, their blood glucoses will come back to normal. But if you have an opportunity, if you think this woman is not going to come back later, or if the woman is on a very high dose of insulin, it makes sense to check glucose values before going home, because in many of our setups, they are there in the hospital for 48 to 72 hours anyway. 6 weeks follow-up visit, please reiterate that they do need to do a GTT, encourage breastfeeding, and then annual follow-up thereafter. It's a big challenge in achieving this postpartum follow-up, and there are many barriers to why women don't do this postpartum GTT, and some of these have been explored in different studies and publications, but this is a focus area where we have to improve and probably look at a test other than the GTT. Now, long-term follow-up is extremely important, because the drivers in mothers with gestational diabetes is inflammation, obesity, and insulin resistance, and we know that this then sets the stage for them to develop metabolic syndrome, type 2 diabetes, cardiovascular disease in the future, and results in epigenetic changes and long-term alteration in fetal fat distribution, resulting the neonate as well. So there is good evidence that you can prevent type 2 conversion of women with GDM to type 2 diabetes with breastfeeding, with reducing interpregnancy weight gain, and studies have shown that weight loss does result in a delay of conversion to type 2 diabetes. and in a select subgroup, metformin therapy is effective for conversion. So the reason I've highlighted this point is that we spend very little time talking to women with GDM about long-term prevention. They don't see any other medical professional. They fall through the gap, and it is in our hands to ensure that we can do this better, focusing on prevention and screening them for other cardiovascular risk factors, because we also know that there's a lot of dyslipidemia in our women, but sometimes when we see them in the postpartum phase, knowing that they've had gestational diabetes, we don't add all these factors and we lose the opportunity to reduce or to introduce lifestyle intervention and prevention for education. And so we are in a unique time in medicine when we can predict future disease and prevent it. And in the context of gestational diabetes, we have the opportunity to prevent it across a generation. Thank you very much.
Thank you, Madam, for that very crisp and elaborate discussion and conversation on GDM. Lola, Madam, will you please conclude?
Yeah, no, I think in the interest